This program is presented by Medscape Education Global.
Hello, I'm Dr. Michael Singer, clinical professor at the University of Texas Health Science Center in San Antonio, and welcome to this program titled Intraocular Inflammation After Anti-VEGF Therapy, the latest data and guidance. Joining me today is my good friend, Dr. Justus Garwig, who is Director of Ophthalmology and Ophthalmic Surgery at the Swiss Eye Institute in Bern, Switzerland. Today, we're going to be discussing how to improve the diagnosis and management of intraocular inflammation after anti-VEGF therapy with retinal diseases. We currently have 3 approved anti-VEGF therapies for wet macular degeneration. We have aflibercept, ranibizumab, and brolucizumab. And patients targeted with these agents sometimes can experience intraocular inflammation. If left undiagnosed or untreated, could lead to complications such as retinal vasculitis or retinal occlusion. That's why it's really important to us as clinicians to be able to recognize this in our patients and manage them appropriately. But before we take a look and deeper dive into intraocular inflammation, let's touch on the efficacy and durability data with these anti-VEGF agents as a reminder to see why do we use them as first-line therapy in our patients. This slide shows the key phase 3 clinical trials demonstrating the efficacy of these anti-VEGF medications. The Marina and Anchor study looked at ranibizumab in both classic and occult neovascularization and showed that it was highly significant in terms of improving visual acuity compared to standard of care. The View 1 and View 2 trials looked at ranibizumab versus aflibercept and showed that aflibercept was not inferior to ranibizumab in terms of changes in visual acuity, and the dose could be extended up to 2 months. The CAT study compared ranibizumab and bevacizumab and showed no significant difference between the 2 medicines in terms of visual acuity and OCT drying. However, monthly therapy was superior to as-needed therapy with both of these medications. There was a 5-year follow-up that showed that the visual acuity gains in CAT were lost over time. The Horizon study showed the similar things in ranibizumab and the Anchor Marina, that all the gains you got were lost over 5 years, and then the 7-Up study showed that even further loss was due to geographic atrophy and worsening of wet macular degeneration in terms of fibrosis and loss of vision. With that being said, I'm going to turn to my friend Justus because all these studies were done primarily in the United States. He's going to go over the AURA study, which could show the real-world experience with anti-VEGF therapy outside the US. Justus.
Thanks, Michael. The real-world problem with anti-VEGF therapy in the early years was treatment adherence, because people were not willing and not able to follow treatment every month, or at least have controls every month. That explains why there was a strong decline in visual gains over time. And that was in all countries, in all studies, and basically the result from undertreatment.
Thanks, Justus. The Hawk and Harrier studies looked at 2 doses of brolucizumab versus aflibercept. The patients in the Hawk and Harrier trials showed with brolucizumab you could get robust visual gains and favorable anatomic outcomes in over 50% of patients on Q12 dosing after the initial loading dose until week 48. And if you look at the OCT findings, you can see that during the match phase, brolucizumab did a better job of drying than aflibercept, and this improvement in drying was seen all the way through the study. And you can look at patients with intraretinal and subretinal fluid at both 16, 48, and 96 weeks, and you can see very clearly that more patients on 6 milligram brolucizumab were drier in terms of the intraretinal fluid and subretinal fluid components versus the other patients in aflibercept. You're able to not only improve the vision on Q12-week dosing, you're also able to maintain the OCT drying effect up to week 48. And inflammation is something that is present when you treat patients with brolucizumab. The overall rate of brolucizumab in the Hawk and Harrier trials, it was about 4.4%. The intraocular adverse events in terms of intraocular inflammation, basically 50% of these were diagnosed as mild by the investigators, and the vast majority presented within 6 months. Most of them were treated topically with topical steroids or systemic, and intraocular steroids weren't used much at all. Numerically, more patients gained 15 letters than lost 15 letters, and the majority of patients with intraocular inflammation and retinal artery occlusion, which is obviously the most significant manifestation, lost vision over time. So if you were unlucky enough to have an artery occlusion, that had a bad prognosis. But 3/4 of these people, despite having inflammation, continued to receive brolucizumab after the inflammatory event was over. What do you need to know when you see a patient with intraocular inflammation? It turns out the vast majority present within 6 months. And if you look at the median days, it's about 100 days since the start of brolucizumab injections. And then if you look, how long will it be after the last shot? The median here was about 18 days. Why is this important? Because this differs significantly from patients who present with endophthalmitis, who you see somewhere between 3 and 7 days after the initial injection. So the time course is important to understand that these patients present later, and it may have to do with the underlying mechanism of why these patients develop inflammation. The overall incidence of inflammation is about 4.6%. When you go to vasculitis, this basically decreases to 3.3%. And when you go to vasculitis and artery occlusion, it goes down to 2.1%. It's important to realize that it's a very small number of people, but those who have significant inflammation may have significant visual loss. The SRC Safety Review Committee was formed with Jeff HARRIER as the chair, and they looked very clearly about what was going on and what was involved. And they found overall pretty much similar things, that essentially instead of 4.4, it was 4.6% of people had inflammation and retinal vasculitis. When you dig deeper, you cut down that it basically inflammation and just vasculitis was 3.3%, and then inflammation, vasculitis, and occlusion was 2.1%. And then the risk of severe visual loss, which is greater than 15 letters or more, was only less than 1%. They looked at all the pictures, they looked at all the OCTs, and they were able to identify cases of inflammation that were different than the investigators, because the investigators had to do it in real time. We know that this is not only related just to brolucizumab. Inflammation and vasculitis have been seen in anti-VEGFs, and basically it's a newer phenomenon because we're starting to use newer anti-VEGF agents. And the hypothesis to explain this are immunogenic, but we haven't figured out what's involved in the process. So I'm going to turn it over to Justin to talk about Eric Swede's paper, who looked at inflammation with other agents other than brolucizumab.
Thanks, Michael, for what we know from history from intraocular inflammation in the context of anti-VEGF treatment. Since the early days of anti-VEGF treatment, and for any drug, there were inflammation. It was like 1.1% from November 2011 to April 2012, and it increased to 1.9% from May 2013 to August 2013. This increase may have been linked to the new marketing of aflibercept, which was in the early days also linked with inflammation signals. The difference to the intraocular inflammation observed with brolucizumab is it was as well as steroid inflammation, but it disappeared without systemic treatment, and it did not go along with vascular occlusion. If you look at the more recent databases from IRIS and Komodo, those are more recent observational retrospective studies done in the US with a follow-up time limited to 6 months. But both of the studies are large databases, so they give very good information in general, though they do not provide access to the patient charts. We have no clinical outcomes, we cannot say anything about that, only what the number of event was. And if you look in the IRIS registry, which covered 10,600 and a few cases, they found nearly 2.4% of intraocular inflammations. The Komodo database included 11,100 and a few patients, and they came to a very similar outcome of 2.4% of intraocular inflammation related adverse events. But if you look more closely, then you see that only 0.5% of all cases, or 0.56% of cases had retinal vascular occlusion or retinal vasculitis. And this is the most important finding linked to severe vision loss in the both US databases. Those information were consistent with that was reported from HARRIER and HAWK trial that has to be mentioned. So it's a real life registry, and we do not have the outcome because it's only an observed risk rate, but it's a very large database, and so far it presents pretty robust safety data. The potential risk factors were analyzed based on the data available, and they showed if patients had no prior risk of IOI, they had a less than 2% risk of any intraocular inflammation, whereas patients with a prior intraocular inflammation or retinal vascular occlusion had an almost 9% risk of complications in the iris, and similar numbers, 2% risk of complications with no prior intraocular inflammation, but more than 10% risk if IOI was present. This indicates that patients with IOI or vascular occlusion in the last 12 months prior to the first brolucizumab injection were more likely to present with similar events within the 6 months after brolucizumab injection than patients with no prior history of these events. This is strongly evidencing that if a patient has a history of inflammation or has a history of vascular occlusion within the eye, you should not go for brolucizumab treatment. If you look in more detail to the complications rate, the cases that presented with intraocular inflammation or vascular occlusion, the 0.5% of cases in IRIS and Komodo, then you again see that the number of cases without prior history is significant, more than tenfold lower than that with a history of prior IOI, again giving strong evidence that cases that present with a history of inflammation or vascular occlusion within the eye should not be treated with brolucizumab according to current knowledge. And with that, I hand over to Michael to present how to handle IOI if it arises.
Justin, thank you so much. One of the things that you just showed very clearly to us is that lots of different ways of looking at it come up with the same basic numbers, which is really important to understand. We want to put this in perspective. We're looking at small numbers of people, and some of them having pre-existing inflammatory issues may put them at greater risk for having a negative reaction to a brolucizumab shot. So now what do you do when you get it? There are two basic trials that looked at this. Very clearly, Frank Holt really looked at this in greater detail, and we basically brought it down into two basic categories, whether it's just anterior uveitis alone or intermediate uveitis, posterior uveitis, and posterior vasculitis. When you have anterior uveitis, topical corticosteroids do a really good job. You want to do frequent administration, you want to taper, you want to dose based on the individual, you want to use mydriasis, you want to treat it like a typical iritis patient. Only if it spreads to the posterior chamber do you want to look at more aggressive medications like intravitreal injection or systemic therapy. If it presents with intermediate uveitis and posterior uveitis or retinal vasculitis, then you want to start looking and bringing out much stronger therapy like systemic therapy with corticosteroids. You want to use oral, IV, and intraocular steroids if indeed you present with this. And you want to be pretty aggressive from the start. You want to treat them at high doses, and then you can taper them over time. If they develop secondary neovascularization, you may want to consider doing panretinal photocoagulation to the areas that have ischemia. Vitrectomy really doesn't show a whole lot of benefit unless you have vitreous hemorrhage. If the vitreous is heavily involved in terms of the fact that you can't see through it, you might want to consider a vitrectomy. After these cases were reported, a group of experts were assembled together to try to figure out what was the cause of this process. Basically, one group was tasked with going with root cause analysis. One was trying to figure out patients who were at risk, and basically you saw the Komodo and the IRIS database. And then there was a group that had to deal with treatment. How do we give you an algorithm so we can figure out how to diagnose them, what to look for, and what's involved? And obviously what we wanted to do is talk about how does it present? Similar to Frank's study where we talk about, is it the front of the eye or the back of the eye? We recommend appropriate imaging based on location and findings. We showed some cases that really showed this, and obviously we'll show you cases later. And we talked about various treatment options and the time course, and we tried to create a decision tree. And when you look at the decision tree, it's broken down into three major categories, similar to what the SRC talked about. Intraocular inflammation in general, but more likely more anterior inflammation, retinal vasculitis, and retinal artery occlusion. And essentially, how do people present? They typically present for intraocular inflammation with floaters and pain and pressure and discomfort, usually greater than 2 days after the injection, more likely 2 weeks. They'll have light sensitivity and reduced vision. Essentially, you should do a complete eye exam, especially focusing on the anterior and posterior chamber. Try to get fluorescein angiogram, peripheral sweeps if you can, or obviously you want to make sure that that you can differentiate it from endophthalmitis, which can present in a similar way. Once you realize it's inflammation, you want to do intensive topical therapy. You want to have a very low threshold for adding intravitreal or systemic corticosteroids. If they present retinal vasculitis, similar workup, but you really want to work hard to get peripheral views on both your OCT and your fluorescein angiograms, because sometimes the vasculitis doesn't present centrally, it presents peripherally. You'll see perivascular sheathing, you'll see vascular leakage on fluorescein angiograms and delayed retinal filling. You may have optic nerve leakage and hyperfluorescence. In this situation, you want to, you're going to use topical steroids, but you really should start with intravitreal and systemic steroids, and you may want to start using steroid implants, because that also will essentially give you the most amount of drug to the back of the eye as quickly as possible. Retinal vascular occlusion event presents with sudden loss of vision. You want to differentiate between arterial and venous occlusion. You want to potentially add ICG if you can, as well as wide field, as well as OCT. You're typically going to see cotton wool spots, retinal whitening, cherry red spots, box scarring. You may see non-perfusion. You'll see edema of the optic disc and the macula. You'll see sheathing. You'll see venous and intraretinal hemorrhage and irregular venous caliber. Important at this point, you really are now going for high-dose steroids in the front and the back and systemically. You really want to work hard. You're going to potentially get retinal neovascularization. If you get it, you want to basically consider laser. Vitrectomy is similar to what Frank's study said, can be used in acute and severe cases, but it hasn't been demonstrated to increase the visual improvement. But PRP is something you may want to consider because these patients may have rubiosis in the long term. So with that being said, we're going to talk about 2 of the cases that Justic will present to demonstrate some of these findings.
Thank you, Michael, for explaining the algorithm. The very first or most important thing I have to add to that is if there's anterior uveitis only, you have to be very careful and have to do a dilated fundus examination to be sure you do not miss a spillover to the posterior segment. And the first case I show is a case of a lady who had 4 weeks after her first brolucizumab injection, a mild anterior uveitis only. She had on OCT, you see in the upper line the pre-injection OCT, and in the middle line the 4 weeks post-injection OCT. She had a good response, but if you look carefully, you see those hyperreflective spots in the vitreous, only single spots. But if you do a wide field angiography, then you will see the vascular leakage, which indicates she has active vasculitis. In these cases, we do angiography and we immediately inject 40 milligrams of methylprednisolone intravenously to be sure the vasculitis is treated from a systemic side. Basically, the treatment protocol that is generally following expert opinion is the one that was developed for retinal vasculitis in Behçet's disease or in viral retinal necrosis. You need to go for systemic intravenous treatment if you have occlusive vasculitis. Here, the macula is not involved. The vascular occlusion is only temporal inferiorly, which is the most frequent localization for vascular occlusion. The second case, it was only eye of a less happy guy. He had a bad response to aflibercept needing injections every 4 weeks, and despite that, developing significant and increasing macular edema with intraretinal and subretinal fluid. He responded very well to the first brolucizumab injection, as you can see in the middle OCT. But if you look at the bottom line, then you see 6 weeks after the second VOV injection, on the left side in the red free frame, you see the vitreal opacity indicating a pretty strong vitreal infiltration, which was responsible for a vision drop from 0.6 or 1220 to age 20. And the patient recognized this like a diffuse nebule and not more. If you look at the right side of the OCT frame, you see the hyperreflective spots within the retina and in the pre-retinal space. These are very typical. These are the hallmark of retinal affection. And if you don't treat very aggressively in these cases, then you have no chance to maintain visual acuity. He had significant vascular occlusion, including the macular branches of the retinal artery. He was again treated when we saw this angiogram result, immediately treated with intravenous methylprednisolone along with topical and local corticosteroids, and the outcome was luckily good. He had for 3 days 40 milligrams of methylprednisolone despite having diabetes. We treated him very aggressively, but the outcome was a full recovery of visual acuity to 12/20. And once you have the inflammation under control, the response to treatment despite the inflammation is pretty good. And he needed his next injection only 14 weeks after the last brolucizumab injection. Importantly, in such a situation, you would not want to re-inject brolucizumab, as was done in HARRIER and HAWK. As soon as you have any inflammation, be it mild anterior or be it severe posterior, you never go back to brolucizumab. And with that, this patient ended very luckily. But to summarize, what is a typical finding? It's for the patient, it's a nebule. It's in some cases visual field loss. In the majority of cases, visual acuity loss. And clinically, you do miss the vitreal infiltrates if you do not dilated fundus examination, and you have to look closely at the OCT to look, do you have hyperreflective intra and pre-retinal spots? And with that, I hand back to Michael.
That was great. I mean, you really highlighted the key points involved to help our viewers really understand this. With that being said, so when you switch a patient to brolucizumab, what's your discussion with your patient to increase their education to be aware of this very rare complication?
The very first, we do not treat patients that with only eyes with brolucizumab, because it's an unacceptable risk for them. Secondly, we do not treat patients who need treatment for both eyes, because if you have an event, you're at a risk of having it in both eyes, which means severe vision loss in both eyes is a catastrophe. So that's what we don't do. We do tell them, listen, there is a risk. If you notice any vitreal floaters, if you notice vision loss, if you notice nebule, whenever that is after the injection, you have to come back immediately. It's not painful. You don't have a red eye. If you have just a mild symptom, if that is present and it was not present the day before, you have to refer back immediately. We invite them for a re-examination 10 days after the first injection. This is not for examining the case, but for educational purposes. They do get OCT, they do get a wide dilated funduscopy, but we do not expect to see very much. This is really important for patient education. The 5 cases that I saw, they did have significant problems, and because of being educated strictly, they came back early, and we had lucky outcomes in most of these cases.
That's pretty impressive. So when you start patients on injections, and they did the first injection, you told me you bring them back. As they get subsequent injections, do you examine them every injection, or do you just basically inject them and just depend on them to report when they have symptoms?
Excellent question. What we do is we dilate the fundus before any injection, but only after the first injection we do the educational visit after 10 days. We do not do any educational visit again after second, third, or fourth injection. But at any injection, we do the dilated fundus examination and remind the patients to immediately refer back if they have any suspected symptoms.
In general, we agree, as opposed to our other injections, which we kind of just run them through, don't dilate them and give them injections. These we take very seriously, because some of the incidences of retinal vasculitis or retinal occlusion may be peripheral, and if you catch it early, you may have great success like you showed in your cases. So obviously that's important. The key takeaways from this is what we want to talk about. brolucizumab has great efficacy. It does have this small potential side effect in a very small percentage of people. Education is the key. Usually you don't want to do it in patients who have a history of intraocular inflammation. You want to dilate the patient at every single injection. And you do get inflammation where there's an algorithm. If the inflammation is located essentially in the front of the eye, topical steroids. As it starts to migrate backwards, you want to make sure that you get more intensive steroid therapy, whether it's intravitreal or steroid implants or systemic steroids. You want to be able to be aggressive on the anti-inflammatory medicine to hopefully decrease the sequelae of the complication. But in general, as you can see from the HAWK and HARRIER trials, the majority of people did well, obviously, but the better educated that your patients are, you want to make sure that you're able to catch that, vasculitis and occlusion as soon as it occurs to have the best chance of patients maintaining or gaining vision. What else is on the horizon? So we're going to talk about emerging therapies. Faricimab is a bispecific anti-VEGF, anti-Ang2 molecule. The TENAYA and LUCERNE trials looked at patients who were given faricimab versus aflibercept, and essentially what it showed was that 80% of patients were able to go 12 weeks or longer, and about 50% were able to go 16 weeks or longer, and it had similar reductions in central subfield thickness as aflibercept. There is going to be a long-term study called the AVANEL to get 4-year data. About 50% of people were able to get 16 weeks, whereas almost 80% were able to get every 12 weeks. And you did have a reduction in the number of injections by 2 over the first year of the trial. And in terms of being able to gain vision and not lose vision, it was very similar to aflibercept in both trials. In terms of intraocular inflammation, there was uveitis. There was essentially small numbers of uveitis, and there was basically one case of chorioretinitis, but there wasn't any artery occlusions in the faricimab trial and faricimab arms. And there were, there was one case of endophthalmitis in the aflibercept arm. The other thing that's coming down the road is the port delivery system. And the port delivery system is a ranibizumab pump that is surgically implanted in the eye. You basically take down the conj and you put it in. It's a self-sealing incision. And they ran a study called the Archway trial where they wanted to look at patients given port delivery system with ranibizumab 100 milligrams per millimeters every 24 weeks versus monthly ranibizumab, and there was a 36 and 40-week endpoint. The Archway trial showed that the vision essentially was the same, as well as the OCT reduction was the same between the two arms, and 98% of people were able to go 6 months without a refill. It was well tolerated, and it really was something that we're excited to see. It's a surgical procedure. You have to be really good with taking care of the conjunctiva because the complications have to do with conjunctival erosions and extrusions when they happen, although very rare. So in summary, we know that anti-VEGF medicines work well. We've got 3 really good ones already. Brolucizumab is a new treatment because it's more concentrated. It's very effective in drying the retina, more effective than aflibercept, and achieves similar best-corrected visual acuity. The intraocular inflammation is a concern. The new analysis that we've seen look at this in greater detail. It's important to understand that the vast majority of these will occur within the first 6 months. You want to have a high degree of suspicion for them and treat them aggressively with topical steroids, intraocular steroids, steroid implants, and systemic steroids, depending on what part of the eye it presents in. As Justin said, it's contraindicated in patients with intraocular inflammation, and it's contraindicated in patients who've had an episode of inflammation as well due to brolucizumab. Essentially, if you keep the vigilance up, you definitely can use this medicine in a select group of patients, understanding the risk-benefit profile. What I want to do is thank Justice for all his great discussions, his cases, and his insight on this very interesting topic. And I'm very excited to have had the privilege of sharing the stage with him. Justice?
Thank you for including me in that discussion.
To the audience, thank you for participating in this activity. Please continue to answer the questions that follow to complete the evaluation.
This program was presented by Medscape Education Global.